Hello everyone, myself Dr. Jansiya from Department of Orthodontics and Dentofacial Orthopedics, Vinaya Mission Sankaracharya Dental College, Salem. The topic of the today discussion is orthopedic appliances. This is the overview. Coming to introduction, in 1866 Kinsley, the first reported use of headgear anchorage for correction of protrusion of the upper anterior teeth was made by Kinsley. According to Moyers, extraoral traction devices are those that utilize anchorage outside the oral cavity for efficient application of force in direction and not otherwise possible. Duterlo defined orthopedic effect in orthodontics as a change in the position of bones in the skull and in relation to each other induced by therapy. In orthodontic practice, the force employed are basically of two types: orthodontic force that moves teeth efficiently, orthopedic force that affect the deeper craniofacial structures. Basics for orthopedic appliances. Force applied to the teeth have the potential to radiate outwards and affect the nearby skeletal structures. For such skeletal changes to occur, the force employed should be over 400 grams. In order to produce skeletal changes, consideration should be given to the amount and the duration of force. The duration of force ranging from 12 to 14 hours a day to bring about minimum tooth movement but maximum skeletal changes. Coming to philosophy of extraoral forces, a disproportion in the size or position of the jaw result in a skeletal discrepancy in either sagittal, vertical or transverse planes. To manage and treat this skeletal discrepancy, three different approaches are available. Number one is growth modification, number two is dental camouflage, number three is orthognathic surgery. Growth modification should be opted wherever applicable because this precludes the need for both tooth extraction and surgery. The goal of growth modification is alter the unacceptable skeletal relationship by modifying the patient's remaining facial growth to favorably change the size or position of the jaws. Orthopedic appliances are one of these appliances that are used to modify the growth of maxilla or mandible. Coming to site of anchorage, we can take anchorage from chin and anchorage from skull and also anchorage from chin and foregut. Coming to headgears, headgears are the most commonly used extraoral orthopedic appliances. They are used during the skeletal malocclusion as well as to distalize the maxillary dentition or maxilla itself. Headgears also from one of the important adjuvants to control or gain anchorage. They derive anchorage from the cervical or the cranial regions. Coming to types of headgears, based on the site of anchorage, headgears can be of three types: cervical headgear, occipital headgears and combination headgears. Now another two types are of vertical pull headgears and asymmetrical headgears. Coming to cervical headgear, in this diagram, the cervical headgear is also known as covalent headgear. It exerts distal and extrusal force on the maxillary molars. It is used in lower mandibular angle cases. Coming to occipital headgear, this type of headgear derives anchorage from the back of the head, occipital region. It produces a distal director force on the maxillary teeth and the maxilla. A slight superior director force may also be seen. Here you can see that combination of both cervical and occipital anchorage are combined in this type of headgear. When the force exerted by both are equal, a distal and slight superior director force are exerted on the maxilla and maxillary dentition. Moreover, by varying the proportions of the total force derived from the head cap and the neck strap, the resultant force direction can be altered. Coming to vertical pull headgear, it derives anchorage from the head and the parietal region, this diagram. Therefore, it produces a vertical director force on maxilla and the maxillary dentition. As a result, it is used in individuals whom a decrease in the vertical development of maxilla is required, such as long face in class 2 patients and in patients with open bite tendencies. This headgear also exerts intrusive force on the anterior region of the maxilla, thereby producing a counterclockwise movement of maxilla. Therefore, it is useful in the treatment of vertical maxillary excess and gummy smiles. Intrusive force on the posterior aspect of maxilla can be of benefit in anterior open bite patient as it intrudes the maxillary molar, therefore produce a clockwise movement of the maxilla. Coming to headgears, in headgears we have three main components, that is face bow, the force elements, the head cap or cervical strap. In this diagram you can see the head strap, these are the force elements, this is face bow. The face bow is a metallic component that helps in transmitting the extraoral force on the posterior teeth. This face bow consists of outer bow and inner bow and the junction. This is outer bow and inner bow, and this is the junction. The outer bow is made up of 1.5 mm stiff round wire and is countered to the fit around the face. The outer bow can be short, medium or long. Coming to J hook type of face bow, this type of face bow consists of two 0.072 inch curved wire whose ends from hook that are counted to fit over a small solder stop on the anterior segment of the maxillary arch wire. The normal site of its attachment on the arch wire is between the lateral incisor and the canine. Therefore, it is used along with maxillary fixed appliance having a continuous arch wire to retract maxillary anterior teeth. Coming to the force elements, it is a part of the assembly which provides the force to bring about the desired effect. This may comprise of spring, elastic and other stretchable materials. The force elements connect the face bow to the head cap or neck strap. The head cap or cervical strap, the appliance take anchorage from the rigid bones of the skull or from the back of the neck by means of the head cap or neck strap or a combination of the two. The selection of this depends upon the individual patient needs. Coming to principles in the use of headgears. Headgears have the ability to move the dentition and the maxilla in all three planes of space. The following factors should be considered when planning the use of headgears: the center of resistance of the dentition and center of resistance of the maxilla, the point of origin of the force, the point of attachment of the force. Under clinical condition, the center of resistance of the dental arch is located between the root of premolars. In maxilla, it is believed to exist at the posterior superior aspect of the zygomatico-maxillary sutures. Coming to center of resistance of the maxilla, center of resistance of maxilla can be determined from a lateral cephalogram. This is obtained by drawing a functional occlusal plane and then drawing a plane parallel to the occlusal plane passing through the orbital. These two planes are connected by a right angle line passing through the distal aspect of the maxillary first molar. The center of this line, half of the way mark of this line, denotes the center of resistance of the maxilla. Once determined, this can be transferred clinical onto the patient. The relation of line of force and the center of resistance of the maxillary molar. The line of force passing through the center of resistance cause bodily movement of the maxillary molars. In this slide, the line of force passing above the center of resistance of molar causing distal root tipping. In this slide, the line of passing below the center of resistance of the molar cause distal crown tipping. You can see the distal crown tipping. Coming to length and angulation of the outer bow can affect the line of force. Here A, B, C represent varying lengths and angulation of the outer bow, but all the three lines of force that passes through the center of resistance of the maxillary molars. Coming to relation of force vector to center of resistance when cervical headgears are used. Here the line of force passes below the center of resistance of both maxillary and the dentition. This produces the clockwise rotation of maxilla as well as the dentition. In this diagram, you can see the line of force passes below the center of resistance of the maxilla and above that of the dentition. This produces clockwise rotation of the maxilla and the anti-clockwise rotation of the dentition. Coming to relation of force vectors to center of resistance when occipital headgears are used. Here the line of force passes below the center of resistance of both maxillary and the dentition. This produces the clockwise rotation of the both maxilla as well as the dentition. Line of force passes below the center of resistance of the maxilla and above that of dentition. This produces a clockwise rotation of the maxilla as well as anti-clockwise rotation of the dentition. Coming to uses of headgears, there are various uses in the headgears. Number one is orthopedic use. The force applied onto the maxilla can be used to restrict its downwards and forward growth. It also used as an anchorage purpose. The extra force are used to reinforce anchorage when those obtained from intraoral sources are insufficient. In maxilla, anchorage reinforcement is achieved by restricting the maxillary movement of molars. We can use as a distalization of maxillary first molar rotation. And also unilateral distalization of molars can be achieved using extraoral force by varying the length of the outer bow. The large force is applied on the side of the longer bow. It can be used in the asymmetrical headgears used for above purpose or generally cervical or combination of the both headgears. The space maintenance and regaining also we can use. The mesial movement of molar is prevented and the face bow does not interfere with the erupting teeth. and also used in overjet reduction. We can use as the intrusion of molars and incisors using in high pull headgear, and also we can use as an expansion or contraction of the arch. We can use as a molar rotation. In order to derotate a molar, the molar has to be banded with the buccal tube placed distally and then subsequently repositioned. The correction is achieved by adjustment of the inner bow so that it produces a rotational force on the molars. We can use it as a retention purpose also. Coming to face mask. Face mask therapy has gained popularity in the last decade. The principle of pulling force on the maxillary structures with reciprocal pushing force on the forehead or mandible through facial anchorage is simple and mechanically sound enough to be used as a therapeutic procedure for treatment of prognathic syndromes and maxillary retrusion, cleft and mandibular prognathism. Hickman 1972 claims he was the first to use the reverse headgear. Coming to petit type of face mask and Turbingen type of face mask. A reversible headgear basically consists of a rigid extraoral framework which takes anchorage from the chin or foregut of both the anterior traction of maxilla using extraoral elastics that generate large amount of force up to 1 kg or more. Coming to indications, it can be used in growing patients having a prognathic mandible and a retrusive maxilla. It can be used for selective rearrangement of the palatal shelves in cleft patients. It can be used in correction of post-surgical relapse after osteotomies. Coming to parts of reversible headgear, we have chin cup, forehead cap, elastics and intraoral appliances and metal frame. In this diagram you can see that with RME with banded. Coming to types of reversible headgear, in this diagram, first slide, you can see the protraction of headgear by Headcam and face mask of Delier. Here, this is Tubinger model and this is petit type of face mask. Coming to biomechanical consideration, the amount of force should be used is 450 grams per side. The direction of force is 50 to 30 degree downward pull to the occlusal plane. It produces a pure forward translated motion of maxilla. The duration of force is 13 months. The frequency of use is 12 to 14 hours wear a day. Coming to chin cup, it is used to restrict the forward and downward growth of the mandible. Chin cup therapy has been widely used for treating class 3 malocclusion. Chin cup is the preferred appliances for growing children with mandibular prognathism. It is designed to suppress or redirect the mandibular growth. Coming to types of chin cup, we have two types: occipital pull chin cup, vertical pull chin cup. In this diagram you can see that here occipital pull chin cup, this is vertical pull chin cup. Here we have orthopedic effects of the chin cup on the mandibular include redirection of mandibular growth vertically, backward repositioning or rotation of the mandible, a remodeling of the mandible with the closure of the glonial angle. Coming to force magnitude and duration of wear, at the time of appliances deliver a force of 150 to 300 grams per side is used. Over next 2 months, force is gradually increased to 450 to 700 grams per side. The patient is asked to wear appliances for 12 to 14 hours a day to achieve the desired results. Coming to conclusion, the choice of appliances should be based on the proper diagnosis of different aspect of the malocclusion and not because a particular appliance is thought to have a greater influence on modifying growth. Clinicians should be thoroughly familiar with appliances they are using, including their potential benefits and limitations. Should also be aware of the biomechanical effect of these appliances on the dentofacial structures when formulating a treatment plan of each individual patient. It is better than cure. It is imperatively that we as a dentist should focus on treating not only those who are ill but also treat those who are more likely to get ill. Thank you.